Welcome everybody, and I'm glad you took time this morning to learn something new about MS. We pride ourselves on our education programs through our MS Center that we try to introduce new and evolving information and science to our lay audience. We pride ourselves that our patients are the most sophisticated in their understanding of the disease, and I hope today I'll take you another step further with that, okay? And this is not easy stuff to understand. And this is also all about change, because we have had what I'll use the terminology, but you'll get some definitions. We have had a phenotypic classification model for MS for the last 20 years that we are now about to abandon, or at least move away from. And in that sense, that's always hard to do. Just as it's still hard for me to work my TV set because there are too many remotes and too many programs, and it is also very difficult to move on into thinking about MS in a new way. But I'm very hopeful that this will be enlightening and will enable you to have discussions about your own disease with your own doctors and care providers in a more informed fashion as you move forward with the disease, and also as you seek additional treatment over the years to come. So what's a phenotype? Well, there's two phenotypes in this room of one category. We've got men and we've got women. So in a sense, your sexual whatever is a phenotype, okay? So a phenotype is simply a descriptive quality or characteristic, if you will. So on this Halloween, I thought we'd start with a particular phenotype, the phenotype of an animal. The squirrel. Okay. All right, so this is really not the usual phenotype you would see with a squirrel, but it was a great photo, so, you know, and it's Halloween, so I thought I'd start with that. But obviously, there are all kinds of ways in which we describe characteristics in disease. So an observable trait could be hair color, it could be height. We can categorize people by these characteristics. We can categorize disease by disease characteristics as well. So what exactly do we mean by a disease phenotype in MS? We mean that there are certain types of MS that behave in certain ways. And we want to be able to categorize MS in a meaningful fashion. Why? In order not only to describe the disease clinically, but also to put it into a category that enables us to predict the future for that disease, to predict response to therapy, okay? So phenotypic descriptions have tremendous value in the medical world. And so as a neurologist, I'm going to give you a different disease and explain. We always talk about Parkinson's disease as being a waiting room diagnosis. What do I mean by that? Well, it turns out that if you look out in the waiting room of a general neurology office, the phenotype of Parkinson's disease is glaring, okay? So I have to do a little physical here, so I hope the camera people will allow me for just a moment. I'm going to do it over here after I trip. What I'm demonstrating are physical characteristics that characterize Parkinson's disease. Loss of facial expression, a flexed posture, and a rest tremor in the hand. Okay, those are some of the features of Parkinson's disease. So we often say that Parkinson's is a phenotype that we can recognize just looking out in the waiting room, okay? That is not true of MS. We look at MS, you look at this room, not a single person here has a phenotype that is visible externally that necessarily tells us your diagnosis. And yet, we need to have phenotypic categorization of this disease so we can put you into a classification that will tell us something about your disease. So everybody, I always like to say in all my talks that no two people with MS are alike. And in a sense, that's true. Symptoms are different, manifestations are different, clinical course is different, and yet we do put people into subgroups in order to do the following: to make the diagnosis, to sort of predict the severity of the disease state, to use features of the phenotype, and those are not on the surface, those are features that we discern by taking the patient's history, by looking at the events that occur along the way, by looking at the assistive data from MRI. All of those things come together for us to know what the phenotype really is. And we use those phenotypic features to then prognosticate, to predict how a patient's going to do. And most importantly, in this day and age of MS treatment, we use phenotypic characteristics to tell us which drug for which group of patients, and therefore which drug for which individual patient. So here are some of the older phenotypic descriptions that we love to use with MS that I wish to debunk a little bit for you. In the bad old days, in the very early days in which I trained, in which there was very little treatment and limited understanding of the disease, we used lots of terms with patients that were phenotypic. We would tell patients, you have benign MS. What was that really? Well, that was a patient having a first attack who got all better. And we said, oh, your MS is benign. In our heads, we knew that this was a bit of a lie because we didn't know who was going to do well and who wasn't going to do well after just one attack. And many people would totally recover after that first attack and look great. And so patients liked that term. People kept that term. People 10 years into their disease, when they were already having walking difficulty, would say, oh, but I have benign MS. My doctor told me that. Well, it's not benign. It's progressing. That's a bad term. The only people these days we should really call benign MS is the patient who comes in after 40 years of disease, has a perfectly normal neurologic exam, and has had it since they were a kid, and yet is completely normal now. So after the fact, retrospectively, we can sometimes identify benign MS. Another favorite term that neurologists sometimes still use is, you have mild MS. Yeah, is that like being a little bit pregnant? You know, if you've got MS, you've got MS, and the truth of the matter is you don't know exactly how you're going to do. So that's really not a fair term, because patients also are very disgruntled when all of a sudden they're not doing well, and yet they're supposed to have mild MS. So that's a term that has pretty much fallen by the wayside. Another old term which I still see pop up in magazines sometimes, which has really been abandoned, is chronic progressive MS. Chronic progressive MS really was used to mean bad MS, okay? Somebody who wasn't doing well. But the truth of the matter is those words, chronic, once you have MS, you have MS. It's a chronic disease. Everybody who has MS has chronic disease. Progressive, a large proportion of our patients have progressive disease, but there's progression that's minimal, okay? There's a foot that's numb, or there's an eye that has a spot in it, and then there are people who are paraplegic. So there are a whole variety of ways in which to progress, and so that term is very nonspecific, and chronic progressive as a category has fallen away. We don't use it anymore. There are still some people who will talk about, and mostly these are doctors, it's a doctor phrase, malignant MS. Somebody has malignant MS, and the term malignant is being used in a way to say very severe, very bad. But the term in the lay world, malignant, is cancerous. And to be sure, this disease is not a cancer. It doesn't affect other organ systems. And using malignant, it has a pejorative or negative implication that really isn't fair. Because a lot of people have progressive or severe disease and lead very productive and very functional lives. And so malignant is a term that I think should kind of be abandoned in our discussion of MS. Okay, so that's the old bad stuff. So why was 1996 a breakthrough year? Well, that was when we first attempted to formally categorize phenotypes of MS and try to divide patients in groups by these descriptors. Okay, and the work was done by a committee appointed by the National MS Society. This was a committee of medical experts, neurologic experts, and investigative neurologists in the field of MS. And really, their main outcome, what they wanted, was to better define patient groups. Why? To put patients into trials. And that is a very important aspect of knowing a patient's phenotype. So here were the many goals that they had at the time. They really wanted to better subdivide patients into how the natural history of their disease went and what their demographics were. So in other words, if you are Caucasian, that's a phenotype. Do you have a more predisposition to having relapsing disease if you're Caucasian? If you're non-Caucasian, are you more likely to have a progressive form of the disease? So they wanted to interlink natural history and demographics. What is the disease like in very young people? What is the disease like in people who start when they're older? What about children? The very neglected group of people with MS, because they're such a small proportion. It's only in the last 10 years that pediatric MS has really been described and studied. So it was one thing to try to describe the natural history. The next goal was to ensure homogeneity, bringing a group together that are all alike for a clinical trial. In the early MS trials years ago, when they studied a drug called Imuran, okay, the trials were very bad. Why? Because all you had to be to get into the trial was to have MS. It didn't matter if you had relapsing, progressive, chronic, whatever. If your MS was stable for 10 years but you were still disabled, you might be in the trial. Well, needless to say, because there was very little homogeneity amongst the patients, it was very difficult to prove that the drug worked, because the disease behavior was so varied in these groups. You really couldn't count relapses if you had people who weren't relapsing in the trial. And so these early trials were a gamish of all kinds of MS, and we didn't really get good quality data out of those trials. So it became very clear that we needed to separate relapsing forms from progressive forms, people having attacks, people not having attacks, people who had mild relapses with very little left over from people who tend to have worse relapses. We needed different groupings in order to do trials that would have meaning and that would give us information about individuals. Also, neurologists needed to know what they were talking about when they talked to each other. So when an MS doctor would talk to another MS doctor and say, I have a patient with MS, the phenotype, the categorization of being able to say it's a relapsing form or it's a progressive form, these were very important in order to foster communication and scientific understanding of the disease. And on an individual basis, we needed these categories so that I could say to a patient on an individual basis what I thought their disease manifested as, which category I thought they were in, what's the likely course of their disease, what might their prognosis be, which is of course what patients want to know right from the get-go. So dividing patients into meaningful phenotypic categories was the goal of that first classification. And here was the outcome. And this is the outcome that you are all probably very familiar with, right? 4 categories only, but 4 very different categories that we thought best separated MS into its meaningful phenotypic characteristics. Relapsing remitting MS, secondary progressive MS, which is people who have had relapsing remitting but then become progressive, we call that secondary progressive. Primary progressive MS, where people have a course that's progressive right from the start. And then a little variant on that, progressive relapsing, which has always been people with what looks like progressive right from the start disease, but every so often have a relapse. So these 4 categories are what has been used for the last 20 years in typifying patients, in identifying clinical characteristics, and in putting patients into trials. And it was useful, it was helpful, but it was a first step. We neurologists, we've been using this classification now for years. Has everybody heard of these categories? Yes? If you've heard of these categories, raise your hand. Okay, so you're all very up to date until this new thing that I'm going to show you today. So we've used these categories routinely in structuring our trials, and the FDA has used these categories when granting approval for drug use, right? So we know that a lot of our disease-modifying drugs can only be used in certain categories of patients. We cannot, for example, give interferons to a patient with primary progressive disease. It's not approved for that. Now, I have to tell you that in the very early years of interferons, which were the first drugs on the market, we gave them to our progressive patients. We gave them off-label, right? Doctors have the freedom sometimes, and before the drugs cost what they cost today, we had more freedom, but we have the freedom sometimes to use a drug in a patient who is not the typical patient in order, hopefully, to help that patient. And in the early years, we used beta interferon in progressive patients, in patients with primary progressive disease. Turned out it didn't work very well. And we stopped doing that based on experiential data. And then later, there were progressive trials done, okay? These days, the FDA is more stringent. They want the disease category, the phenotype, to match what they approve the drug for. And I give you an example of a non-disease modifying drug, Ampyra. Most of you have heard about Ampyra, the walking pill, right? Ampyra was studied in a population of patients with MS who can still walk. And the measurements that were made during the trial were walking speed. When the drug got approved for use, we neurologists who had used some forms of Ampyra for years that were from compounding pharmacies, we used it a lot in our non-walking patients because we thought it helped also with upper body strength, we thought it helped with energy and so forth. But the FDA approved Ampyra only based on the new clinical trials that said this is for patients with the phenotype in MS of being still ambulatory. So that's why we have difficulty using Ampyra in our non-walking patients. We will need new clinical trials and new data, perhaps, to then get a new FDA allowance to use the drug in a different phenotypic category of MS. Okay, so that's just one example. So what's wrong with the classifications that we've been using all these years? Well, the categories, as they were selected by the 1996 panel, were just based on clinical appearance, what they knew subjectively about the disease. What they knew also, there was data about epidemiology, about how MS tended to progress in groups, but it was limited, okay? There were no surrogate markers of disease, specifically MRI characteristics, that were part of the classification scheme. And you who attend with your neurologists know these days how much more emphasis we are now putting on MRI as a guide to how a patient is doing. So it was high time to bring in those MRI categories and markers and integrate them with what we see clinically in patients in order to better phenotype the different disease groups. And so another problem, by the way, with the 1996 categories was there were two new categories over the years since 1996 that have come to be recognized in the MS community. One of those is called clinically isolated syndrome. That means somebody who has one attack, does not yet fit the definition of MS because they've only had one attack in one spot in the nervous system, and they may or may not have a couple of spots on their brain scan. And so that's called clinically isolated syndrome. It's not MS, but it's considered pre-MS, and that wasn't at all part of those phenotypes from 1996, those 4 phenotypes: relapsing, remitting, secondary progressive, primary progressive, progressive relapsing. CIS wasn't in there at all. And another category that was not in there at all was what we call now RIS, radiologically isolated syndrome. I saw one of those patients this week in the office. She was diagnosed with an attack of MS in 2011. But back in 2004, she came to the ER with a headache. They did an MRI then. She had changes of MS on her MRI. She was told about that. She went back to her doctor. She said, what to do? Well, do you have any symptoms? No. Well, then don't worry about it. Okay? We now know that a subset of people who come in never having had a symptom of MS, never having had an attack, and are neurologically normal may have an MRI that is classic for MS. And they probably have MS, but we call that radiologically isolated syndrome because clinically they fit no phenotype, no other phenotype of MS. So this is literally a new phenotypic category, to have a CIS or to be an RIS. That is to have an MRI that shows MS, but you don't have the disease yet. Okay? So we needed to integrate these new understandings into a new classification system. So the push was on in recent years to better develop a classification system that would incorporate our new understanding of MS pathology that is now informing our new drug trials. So we now know much more about the mechanisms of MS, which helps differentiate patients. We realized that the old phenotypes weren't really working adequately to describe everybody. People would say to me, well, am I really this or am I really that? And you know, in the office, I would see a patient with secondary progressive, and I'd know they were a little secondary progressive, but they were coming back with a relapse now and then. So all my secondary progressives were not alike. Clearly, all my relapsing remitters were not alike. There were people who didn't show up for 2 years because they felt fine. And then there were people in my office every 3 months because they're not doing well with relapses. So added to that were going to be the MRI characteristics that were going to help us better categorize disease. So this is what we call the 2013 revisions. It was another committee of experts who got together. They did it through a series of meetings in 2013, and they really didn't bring this classification scheme to the neurologic community at large until 2014 was the first publication, and then there have been more publications since. And we're gradually, kicking and screaming, we're moving to a new way of classifying the disease. It's hard to accept change, but we need these changes to better identify patient groups, okay? So we are still in the 2013 revision talking about relapsing remitting patients and progressive disease. So you either have relapsing remitting disease or you have progressive disease. Then we use different descriptors, so we have to be careful with our language. If we call a patient worsening, what we're saying is that the disease is advancing due to relapses that are in fact leaving leftover damage. So in other words, if I have a relapsing patient and they keep coming in, that patient who comes in every 3 months and they're having lots of relapses and they have leftovers, I'm going to say I have a relapsing patient who is worsening, okay? That's different than disease is progressing. We're going to use the term progressing disease if there is in fact continuous decline in a patient's status, but there are no visible relapses. So the patient who comes in and says, last year I could walk the MS walk, I did 3 miles. This year I did 1 mile and my leg was giving away. But they didn't have a relapse between last year and this year. They've been stable on their drug. That's progressive disease, okay? So those are definitions of terms. The next label that's being used in this new scheme for phenotype is to describe disease as either active or not active. And there are 2 ways you can be active. The 2 ways you can be active is to have new clinical attacks. And there are 2 ways to be active: to have clinical attacks and also to have new stuff on your MRI. Stuff is not a scientific term, however, you all know that there's different stuff that appears on the scans. We get new white spots. That's considered new inflammatory activity. Or old white spots get bigger, which means a plaque has reactivated over time. Or a white spot turns into a hole in the brain. Now you've got what we call black holes. These are all forms of MRI progression, what we would call an active MRI. So If you have new attacks or you have new stuff on your MRI, you are considered active disease. If you do not have either of those requirements, then you are not active. No new clinical attack, no MRI change, you're not active. Now we're going to put it all together. Okay, ready? The patient who comes in with a single attack is a CIS, okay? If they stay with only that attack and have no new MRI stuff and no more attacks, then they are considered to have CIS not active. Okay? CIS not active. And we have a lot of patients who do that. They come in with one optic neuritis, and for years they have no further attack and no new stuff on their scan. Okay? And we have to debate whether to treat those patients or not, but that's what they are. CIS not active. There are patients who are CIS that become active. So they have an optic neuritis, but a year later they're back and there are 2 new spots on the scan, and there's a tingling foot. Well, that's CIS active, but guess what? If they're CIS active, what are they now? Now they have MS, right? So we're going to move them down to relapsing remitting MS, active. So if you have relapsing remitting MS, that means you've already gotten the MS diagnosis. If you're active, we said, that means you're having new stuff on scan or you're having attacks. That means you are relapsing remitting MS and your disease is still active. Okay? Now, if that's the case, your doctor better rethink what you're on, right? It may be time for a new drug. On the other hand, the sweet, sweet endpoint we love in the office is to have somebody with definite relapsing remitting MS. They've had it for 10 years, but they're not active. There's nothing new on the scan. There's nothing new clinically. There are no attacks. The patient feels fine. So you say, hey, the drug's working. Patient's doing well. We've achieved goal. Okay? That's how you categorize CIS and relapsing remitting MS. Okay, what about progressive forms of MS? We still are going to say people have primary progressive MS if they start with progression from the beginning. We're still going to call them secondary progressive MS if, in fact, they used to have relapsing remitting and then moved into a progressive form of MS. Nevertheless, when the patient comes in, we want to know what's their phenotype now. What's their phenotype at this point in time? They have primary progressive. Are they active? Remember active? Active is attack or new stuff on scan. And you go, wait a minute, they have progressive, they can't have attack. Remember that old category we had, progressive relapsing? There are people who look like primary progressive, but every so often have an attack. So if you are in the office with primary progressive and you've had an attack, what I would call you is now active. Active, because you had an attack. You may be active with progression because maybe before you even had that attack, you tell me that my walking's been worse over the last 6 months. And when I examine you, you in fact have weaker legs. But the attack was you had optic neuritis. So you can be active with progression, or you can be active, meaning you've had a new attack, and maybe you have some leftover from that attack, but you haven't been following a continuously progressive course. So that means you were active but without progression. You can be not active. A lot of my patients with progressive disease come in and they have not had an attack and they have absolutely nothing new on scan, but their disease is worse. So that's not active but with progression, okay? And you can be perfect, just like that other category of relapsing patients. You can be not active, nothing new on scan, no relapses. You have the category of progressive disease, but darn it, you haven't progressed. There is no change from last year. And we call that not active and without progression. And you can apply those same 4 groups to people with primary progressive MS or with secondary progressive. It doesn't matter. You start with one of the progressive MSs, and then you decide which of the 4 categories you fall in. What's the importance of these categories? Again, going back, it's to help us prognosticate. If I have a patient with progressive disease who for the last 3 or 4 years has been not active and without progression, I tend to paint a better prognostic picture. Your disease is burned out. It's not doing anything anymore. I predict you're probably going to continue to walk with that walker until forever, until the day you die. You've been walking with that walker for 5 years, you're not any worse. I think that's where you're going to end, okay? And I'm saying that to a 55-year-old patient or a 70-year-old patient. But that may be the pattern of that patient's disease. On the other hand, if I have somebody active with progression who has primary progressive MS, I may say, hey, what? We're doing a drug study. We're doing a clinical trial for primary progressive MS. It's a new drug. It's a pill. This is all true, by the way. And you are the perfect candidate. I need to put you in this trial because maybe then we'll have an option of getting your disease under control, and for sure, you will advance the science by participating in that trial. So these are the ways we phenotype or categorize MS moving forward. Okay, so we're not throwing away the old categories per se. We are redefining them into better subcategories that helps us understand what the disease is doing at a given point in time. So the first question is, how long after an active event do you wait to be called not active? There are no specific time periods that are assigned, but it's easier if you're defined as active because you have an MRI that has a new lesion. That's easy. If 3 months later you get, or 6 months later you get an MRI and there are no new lesions, you're not active from an MRI standpoint. You've gone back to not active. From a clinical standpoint, if you're active because you have a relapse, then your disease is defined as active at that moment. Then as the relapse resolves, with or without leftovers, you would be defined as not active over time that follows, unless again you have a relapse. So I guess what these categories are meant to say is what's going on at this point in time, okay? And it's not like you're going to go home after a relapse and I'm going to call you up in 2 months and say, you doing okay? You've become not active. No, these are categories that are going to be applied at visits with your neurologist and over broad periods of time, okay? So they're not going to be well defined to say, okay, if you're 2 months without a relapse, we're going to recategorize you as not active. If you've had a relapse this year, I'm going to think of your disease as active. I want you to go probably a year, in my clinical experience, on the new drug with no activity to say that you are not active now, okay? So what's the difference between clinical attack and worsening symptoms? So the term worsening in this new phenotypic picture, in this new scale, is meant to say that if you have an optic neuritis and you don't get all better and now you have a blind eye, you have had worsening. So worsening refers to your overall function is now worse as a result of attacks. But worsening symptoms is something we see every day in MS. I've got a bad bladder and now it's worse. That doesn't mean you've had an attack. You've had this leftover of a bad bladder and now your bladder symptoms have gotten worse. We're going to figure out whether you're worse because you have a UTI. Are you worse because now you have a dropped bladder? Are you worse because you're drinking too much caffeine? Or are you worse for some other reason? So worsening symptoms per se does not define active, not active, okay? So don't let the worsening or the day-to-day fluctuations be the way you think of recategorizing yourself in these disease categories. This question is, how is data produced and entered? Well, data is gathered by neurologists doing an examination, by taking a history. So when that patient tells me they walk worse and I find on my exam that they walk worse, that's data. Then there's data from MRI. There's data we gather from other kinds of testing, right? I send people to the ophthalmologist to gather data about that optic nerve, or to do a test called an OCT that measures transmission through the retina and tells me whether their optic nerve is actually degenerating. There's data we gather from lab testing. If we're worried about whether a drug is working or not, sometimes there are markers on labs that help us. Or if we're worried that a drug is in fact not doing well, that's data we're gathering all the time. We are also gathering data these days in the form of biomarkers, okay? So biomarkers, for example, if you have an antibody to a drug, against the drug, and that's a neutralizing antibody, that is, that antibody gets in the way of that drug doing its job, that's a marker. So if I have a patient who comes in and they are on a high-dose, high-frequency interferon, and they're not doing well, they've had an attack, so they're active. Or they are doing well, but their scan says they're not, because there's new stuff. I might check their bloodstream for a neutralizing antibody. If they have a high neutralizing antibody, I'm going to say, there's a problem here with interferon for you, and we're going to move on. So that's data that's going to help reconnect what's happening with the patient's phenotype and what the drug is doing. Are MRIs the only way to confirm a patient is out of remission? So, remission means a lot of different things. Notice that remission is nowhere in this phenotypic classification scheme. Okay, we're not using the term remission. We're using the term active, not active. Thanks, Corey. So, MRI is in fact our only non-clinical marker for sure right now that tells us about disease activity. That is correct. Plain and simple. We do not have a blood test to tell us whether your disease is active. Not yet. We do not have blood tests that tell us which of the disease-modifying drugs would be the best drug for you. Not yet. So, yes, MRI is the only other marker other than looking at the patient. It's always good to look at the patient, you know? Talking to the patient. That's why I really don't like treating relapses over the phone with steroids, because you're not looking at the patient. You're not reconsidering that patient's phenotype. Have they gone from a not active form to an active form? Have they gone from just worsening symptoms to, in fact, progressive disease? You need them in front of your eyes, talking and doing an exam to know those things. So what he's asking is, if the MRI is not active, but you're seeing progression, is that meaningful clinically? Yes. That puts you into well, I don't know what kind of disease you have, but that means not active with progression. Remember that category? Okay? Not active, but with progression. That's something the doctor needs to pay attention to. They've lost control of the disease. Now, that doesn't mean they got a fix for it, but we don't have control of the disease. All right? How does MS cause degeneration of the optic nerve? Does this result in blindness? So, there's two ways. You can get optic neuritis, which is an attack on the nerve, just like the attacks in the brain, of areas of inflammation that cut off transmission through the optic nerve, which will cause defects in the visual field, which makes you have blurred vision, spotty vision, no vision, lots of that. Then you may completely recover from that optic neuritis, or you may not. You may have leftover. So that's having residual. So if you've had an attack with optic neuritis, you have relapsing remitting, and I don't want, that's going to be Amy. Amy's here, and she's going to use that. But that's one way that you can have worsening disease, right? But another way is in progression of the disease. Sometimes part of progressive disease is that the optic nerve slowly over years thins. You going to be talking about that, Amy? Thinning of the optic nerve over time, just atrophy. And so sometimes we'll see patients with progressive disease who have not had an attack. They have not had an attack, not active. They do not have new stuff on their MRI scan or in their optic nerve, not active. But they're progressively having some worsening of vision. So in fact, yes, you can have worsening of your vision as part of progression. Okay. Is there an age limit for studies? People always want to know this because people always are upset if we don't take older people. And the truth is, you know, the population is aging. You sit in my office, you'd think the average age of MS was 50, and that's only because I've aged with my patients and we're all there. You know, we're all older. But the reason for age limits in studies is simply this. You get more active disease earlier in the disease particularly with relapsing forms of the disease. So if you bring in a wider age range, even though there are 65-year-olds who sometimes have relapses, you don't enrich your study for getting a definitive outcome. They need the younger, more active disease patients to actually get a measurement in only a 2-year trial that will be meaningful. So, and of course, older people also have more comorbidities, meaning more other diseases that could complicate the picture. If you put patients into trials who also have diabetes, who've also been treated for a cancer with a chemotherapy, who also have sleep apnea, you may get clinical outcomes that blur the lines about what their MS is doing. Okay, so that's the reason that not all ages go into trials. Another symptom question: if there is increasing fatigue, but nothing on MRI, is this considered active? And I have to tell you that a lot of people will have intensification of fatigue as the beginning of a relapse. But we usually can't just say that fatigue itself alone as a symptom tells us that somebody is relapsing, because a lot of people just over the course of their illness do have progressive fatigue. Very hard to measure fatigue objectively. So the answer to the question is no. If just fatigue is worsening, we're going to call that a symptom, and we're going to say you've got a worsening symptom and we need to address it, but it will not change your phenotypic category to call you active, not active, progression, not progression. Okay? So that's a very good example, very good questions. All of these questions were great, guys. All right, I'll let you move on. Thank you.